Hello again. We're still on the subject of cardiovascular system. The first one we did was on hypertension. This one is another very important topic, and that's on heart failure. Heart failure is increasingly common now. We see that in not only in the elderly people, but actually in the younger age groups as well. Even as young as like people in their 20s suffer from heart failure. It's just that we know and we are aware that it can occur at any age group, that we can treat it properly. Heart failure means failure of the heart. That means the heart is unable to pump the amount of blood which is required to maintain adequate circulation. And when that happens, the pump doesn't work properly. There's going to be more and more congestion behind, and patient will become symptomatic with either having pulmonary edema or peripheral edema. So we need to be really, really vigilant about it. If somebody walks in the clinic and they're breathless or they complain of breathing problems in the middle of the night and they've got sweating and simultaneously they also have ankle swelling, which gets worse during the day, and they're not on any medications, always have a very broad mind about them having high blood pressure, having heart failure. There are two types of heart failure which are based on the echo findings. One of them is called as the heart failure with preserved ejection fraction. These are the people who often have an ejection fraction of 55% or more. Now, what ejection fraction really means is the fraction of blood that is pumped out of the heart in one push. And so about 55% of the blood is pushed out of the heart. So that means 45% remains behind. But that is enough to actually maintain a bit of pressure inside the ventricle. Um, so these are the people who've got heart failure. They're symptomatic of heart failure, but they've got a good ejection fraction. And then you've got the second class of people who've got heart failure with reduced ejection fraction. These are often the people who've got a ejection fraction of less than 45. It's very easy to pick these ones up because when you do an echocardiogram and you've got symptoms, the echocardiogram tells you that the ejection fraction is less than 45, and then so you can easily correlate the echo findings with the clinical findings and treat them appropriately. But this is a tricky bit because often I've seen patients suspected of having heart failure, but then they get an echocardiogram. Recently, I saw an echo report, and the ejection fraction was 73%. And everybody was happy that they haven't got low ejection fraction, but this gentleman was still having paroxysmal nocturnal dyspnea, which was the reason why this was done. So if somebody comes to you with heart failure with reduced ejection fraction, that means the heart size has increased, the heart muscle is flabby, and it cannot pump the amount of blood that is required to pump. So what you need to do here is, first of all, as it happens more and more, there is more and more sympathetic overstimulation, there is more and more working on the heart, and then simultaneously you've got problems with the kidneys as well. So you've got more renin-angiotensin being produced. So the body tends to retain more salt and more water, and when that happens, it acts to burden the heart. So heart failure with reduced ejection fraction, the first medication that you use is a beta blocker. You tend to bring the heart rate down to about 65 or below. The second medication to use is symptomatic relief with a diuretic. The third, and this can be tapered according to the response. The third medicine is going to be an ACE inhibitor or an ARB. And lastly, we've got the other group of drugs, which are called as the ARNIs, angiotensin receptor and neprilysin inhibitors. So the ARNI. So if you use an ARNI, you don't have to use an ACE inhibitor or an ARB because you have to use one. These three or four, whichever you add and however you add them. For instance, somebody may not need a very high dose of diuretic because an ARNI may be enough. But these are the essential four segments of treatment of heart failure with reduced ejection fraction. But as I said earlier on, the tricky bit is heart failure with a preserved ejection fraction. What do you do with that? Now, these are the people who've got a left ventricle, which is actually not flabby, it's not dilated, but it's small in volume, and that's because of either left ventricular hypertrophy, which has occurred over a period of time, or for instance, they've got hypertrophic obstructive cardiomyopathy. And these are the people who've actually got reduced intervention, and so therefore the blood that comes in it tends to push it out quickly because you've got the body which needs lots and lots of blood. The body wants to work, the brain wants to work, the muscles want to work, but the volume of blood is low per ejection. And so therefore it has to do that repeatedly and forcefully. And when it does it forcefully, it tends to aggravate the heart failure because by doing it forcefully, the heart muscle tends to tire out. And there isn't enough time for diastolic filling. So when there is reduced time for diastolic filling, the total volume of blood that goes out is less. And these people will often present not with paroxysmal nocturnal dyspnea, as you had them in heart failure with reduced ejection fraction. These people will present with exertional breathlessness. So, exertional breathlessness is going to be perhaps the first symptom of heart failure with preserved ejection fraction, and these people often will be hypertensive. Heart failure with reduced ejection fraction, these people will often be diabetics because we know diabetes causes vascular problems and that also causes cardiomyopathy. So, diabetic cardiomyopathy is very common. Now, importantly, with heart failure with preserved ejection fraction, you would give a diuretic, you would use an ACE inhibitor, and you can use an ARNI as well. But when it comes to a beta blocker, if you reduce the heart rate to below a certain level, these patients will become more symptomatic. So you can't reduce the heart rate to below a certain level in these patients. So you have to be very careful when you're titrating the dose of beta blockers to make sure that you need to stop it where you think the patient is going to not become symptomatic, because when you reduce the heart rate, the heart volume, the left ventricular volume is already small. And so when the left ventricular volume is small, it needs to pump frequently in order to maintain the circulation. But when you slow it down, you can't do anything about the hypertrophy. That's already there. But when you slow it down, you're going to cause more symptoms because once again, the body is going to be deprived of blood circulation. And when that happens, these patients become more symptomatic of fatigue. So, very important, heart failure with preserved ejection fraction, be careful using a beta blocker. Do not use it in maximum doses. While heart failure with reduced ejection fraction, use it in maximum doses, bring the heart rate down, but not in heart failure with preserved ejection fraction. The other most important thing is whenever in doubt and you're in a clinic and you get an echo and you suspect somebody has got heart failure, always do a BNP test because a BNP is going to guide you whether they've got heart failure or not. Thank you very much.